We are.
Hello, everyone. Welcome. We're so glad you're here. Going to have a large waiting room. So going to give everybody just a minute to get in, allow us to admit participants. And just a reminder to put yourself on mute when you join. Happy to have you all. We'll be starting momentarily. Welcome, welcome. So great to have you all. Just going to give a few moments. We still have people in the waiting room. So as we let them in, welcome. And just a reminder to put yourself on mute. And you're welcome to connect with people in the chat. It's a great group. We're already up well over 100. And so feel free to utilize that chat.
I know that voice.
Hello, all, and welcome. So glad to have you with us all joining today. I know there'll be more joining, but we want to, in the interest of our amazing speakers and panel that we have in front of us today, I want to make sure we have ample time to go through. And so I just want to welcome you all on behalf of the National Healthcare for the Homeless Council. We are thrilled to have you here for our Dissecting Street Medicine Landscape Analysis with street medicine leaders. We are so fortunate to have incredible experts joining us today for this panel. I'm going to start by handing it off to Brett Feldman. Just a reminder, this will be recorded. It will be available up on our website. We'll make sure you all have that link. Afterwards, it will also, we welcome you to utilize the chat as a way to introduce yourselves, connect with your colleagues. We will do our best to manage any questions that come up in there. As they arise, to ask of our panel, make sure that Brett has them, but please don't hesitate to re-enter if you think that it is a lively chat and maybe I missed it as I was scrolling through. And without further delay, I am going to turn it over to Brett Feldman from the USC Street Medicine team. So great to have you here, Brett. Thank you for being here.
Oh, thank you so much. It's always wonderful to see you. I'm sorry Barbara can't join us today. Well, we definitely miss her. And thank you for everyone else for joining too. I know that it's a sacrifice to get on a webinar during the middle of the day, especially when many of you are taking care of patients or supporting folks who are taking care of patients. And today is very exciting for me, hopefully for you too, because after my presentation is done, we have a panel discussion with some of the founders of the global street medicine movement, Jim O'Connell, Jim Withers, and we're also joined by Corrine Feldman and Joseph Becerra, who you'll meet later. So the kind of run of show is to have a PowerPoint to go over the landscape study. It's long if you haven't had the chance to read it. Go into the panel and then leave room at the end for discussion. And so the landscape study that we're going to be going over was really the first look at the breadth and depth of street medicine in multiple locations, at least multiple cities. So we called it a celebration of unity and diversity, the results from a comprehensive California street medicine landscape study. And it's by all of us. So this is not my presentation, but really a compilation of all the information that everybody had shared with us during this process. So just to go over some of the methods, there was a number of things that we did. We started with an in-depth survey of all the street medicine teams that we knew of in California. Of course, asked people to refer friends that maybe we didn't know. We did in-person site visits and created Invisible People video series, if you're interested in looking that up. And then did semi-structured interviews with street medicine programs, community partners, managed care organizations, and the California Department of Healthcare Services. For those of you who aren't familiar with that, they essentially manage Medi-Cal in California and help drive policy. And so the question is, homelessness has been a crisis for quite a long time in California. Street medicine programs have been around for 30 plus years. Why did we do this landscape analysis now? And the answer is because now is the right time. And we got funding to do it now, thanks to the California Healthcare Foundation. So that's always a factor. So the reason why this was so important in California is because 50% of the unsheltered homeless population in the whole country resides in California. And we have been seeing large increases in homelessness and especially homeless deaths. In 2021 was the first time that we passed over 2,000 deaths just in the city of Los Angeles. Other cities in California, unfortunately, follow a similar curve, but there was something very striking about crossing that 2,000 mark. We saw within USC and the consultations we're getting from USC and the Street Medicine Institute that the number of inquiries from California were rising very rapidly. These are just the consultations that I had done. And you can see, so California are the orange bars, and then the rest of the country or world actually was the blue bars. So you could see California was starting to outpace the rest of the country, which was really striking for us and kind of alerted us that something is happening in this state. And aside from the kind of collective street medicine excitement, we saw that others were starting to get interested too for the first time. Up until a few years ago, I had actually never talked to a managed care organization, and now we were hearing from them. And some of the comments they made were, street medicine is the best model to meet people where they are, while we're at the same time trying to do something a lot more sensible than having 60,000 plus Angelenos living on the streets. Another managed care organization commented, there needs to be significant efforts and intervention to reach out to them and improve the overall quality of health. It has to begin with street medicine because those are the programs that are best positioned to know their community needs and how to support their members. And Department of Healthcare Services seem to be very interested in this work too. We have a governor who is very focused on improving access to appropriate services. And so when all the stars aligned, you move as fast as you can, you get the structures in place, and you appreciate that support and vision, and you run with it. And then finally, our community partners. I really so greatly believe in street medicine, in the philosophy, the way it engages people. From a person that was living outside for a long time, the world is against you. There's just that general feeling of hopelessness. You're like, nobody cares. And street medicine can completely turn that around. And so this was the background, the landscape that the landscape analysis was conducted under. There was also this political pressure that was starting to build. There was the AB 369, which was introduced by Senator Kamlager. CalAIM was being rolled out in California. And these things are all kind of beyond the scope of the landscape. And then a clarification for billing guidelines, which really was the first time street medicine was allowed to be billed, very clearly allowed to be billed. And so when we go back to street medicine, the very first thing we had to do in this was define street medicine, because it had never been defined in an official way before. And so we really looked to our founders to help us and guide us in everything in street medicine. The first one I want to introduce you to, if you don't know him, is Jack Prager. He's a Welsh physician that did his work in Calcutta. And he did a lot of the leprosy work with Mother Teresa, and he has some great Mother Teresa stories. He said, it's great to have a living saint, but not to work for one. And of course, the two folks you'll meet today, Jim O'Connell and Jim Withers, the founders of the global street medicine movement, in a lot of ways, just healthcare for the homeless, some of the first to really say, the people on the street are suffering and they might need something different than what the system is offering at this time. And so the historic definition of street medicine is the direct delivery of healthcare to the rough sleeping population, so specifically the unsheltered homeless. All the care is performed on the street in their environment. It's typically done through walking rounds, motorcycles, horsebacks, kayaks. We've seen it done many places in many different forms throughout the world. But it doesn't matter how it's done, really. The idea is that you're going to the people, delivering healthcare in their environment on their terms. Since the landscape analysis, this has actually been more codified. Even though it's outside of the analysis that we're going over, I thought it was important to share with everybody. In California, street medicine the Department of Healthcare Services issued an all plan letter, which is how they inform policy with the plans that more officially define street medicine as care provided to an unsheltered homeless individual in their lived environment. Services provided at shelters, mobile units, RVs, and other sites with a fixed specified location do not qualify as street medicine. However, if a mobile unit or RV goes to an encampment in the parks to see an individual, this is street medicine. So again, the idea is that you're going to the people. And then hot off the presses, if you haven't heard, CMS, so this is the federal government, has issued a new place of service code for street medicine, 27, which effectively makes street medicine reimbursable nationwide. And they define it as a non-permanent location on the street or found environment, not described by any other place of service code, where health professionals provide preventative screening, diagnostic, and/or treatment services to unsheltered homeless individuals. So you see, we've gotten to the point that we have consensus, both federally in California and in line with the historical and operating definition globally in street medicine. And the reason why this was important, because as we started the landscape analysis, we wanted to survey street medicine programs. So we had to start with this definition. And so you see, as this kind of went on, we were able to more clearly identify that there was a continuum of medical outreach. And this graphic was brought to us from National Healthcare for the Homeless that showed street medicine on one end, mobile units on the other end, but still a continuum of medical outreach. And it's important that these are distinguished from each other, both from a philosophical standpoint, but also a practical standpoint. Philosophically, we want to be able to suspend our reality and meet the people in their reality where they feel most comfortable, to intentionally flip a power dynamic in their favor. Even if we drive in proximity to them and park and bring them into our environment, it flips that power dynamic back in our favor where we don't want it. Practically speaking, when you have a mobile unit, and then you park it, it now becomes a fixed site. And so the same barriers, like folks not being able to leave their encampment because things might get stolen, are still factors with a parked mobile van, just like a fixed brick and mortar clinic. And so that's the reason why the need is to continue to go to the people and search for that very last one. And so I see these things and people think, oh, Brett doesn't like mobile clinics. And that is absolutely not true. I really like mobile clinics. There needs to be more mobile clinics. The idea is that there's a continuum and they're different. And so when you say, well, how are we going to reconcile this? We, of course, look to my son, Hank. Hank is 9. He has autism, and he's also, we call him the teacher of love, and he has some great things to share with us. And he says, Daddy, it's not bad. It's just different. It's okay to be different. And so when we get to street medicine and how it actually operates, and this came out in the interviews in the landscape analysis, was that it was very consistent. Usually folks had a pickup truck, maybe sometimes a Sprinter van that would actually go to the people. We, of course, understanding that healthcare is much more than an office visit, even if that office is under the bridge. We heard that folks were drawing labs, dispensing medications, doing ultrasounds on the back of truck beds. And we wanted to very complex wound care. And we wanted to hear about, well, how often is this actually happening? And so when we think about how a street medicine friendly system views street medicine from a system standpoint, this is the perspective that we usually get, is that most of the care is delivered by hospitals and clinics and mobile units, and street medicine kind of serves as this water that kind of runs through everything, blending everything together. And when you look from a system-centric standpoint, that looks fairly right. In the landscape analysis, we found that actually over 90% of people were insured. But from the street standpoint, it looks very different. When you talk to street medicine providers, this is what we're actually experiencing, where a patient might bop in and out of a hospital or in and out of a clinic or stop by a mobile unit, but that the continuity, the bulk of the care is actually provided by street medicine. And that's what the data supports when it's gathered from the street. There was a study that was actually done in New York City that showed only 8% of folks identified as having a PCP. We do a lot of surveying in LA and found that about 14% identify as having a PCP or a healthcare provider who cares for them other than the ER. And when we ask providers, what are you experiencing? This is what they said. Was our community only the people who are coming to us, or was our community a larger version of that extended beyond our four walls? When I decided that I needed to be outside with the people, that my community extended beyond the hospital, I left to start doing street medicine. And another, I think our patients more than anyone can speak to the value of street medicine. Historically, they haven't had the best experience with healthcare. They haven't had any medical provider. And so who were these programs that have started doing this? Where were they in California? So this was done over a year ago, this survey. And at the time, we found 26 programs that were doing street medicine in California, which is really a very high number. Actually, it seemed high at the time. I updated this for us today. There's now 49 known street medicine programs in California, and actually many, many more in development for a number of reasons that's beyond the scope of this webinar. But we host the California Street Medicine Collaborative. We have 130 member organizations. About 30 or so are actually managed care organizations, and maybe, of course, the 49 active programs and maybe another 30 in development. It's or 20 to 30 in development. It's really staggering. So what are the organizational types doing this? There's folks from all different types of organizations doing this work. FQHCs were the most common, and it was less than 50% were FQHCs by just barely. So this means that any intervention that we're doing to try and promote street medicine or promote care for people experiencing unsheltered homelessness needs to work for everybody. Sometimes you might focus on a policy that might help one of these types over another, which is okay, but it's not complete until everybody who wants to do street medicine can do street medicine. So for example, one of the first things we wanted to do is make sure that FQHCs could bill their PPS rate on the street. And that's great. It didn't impact the non-FQHCs. We also wanted to make sure that hospital presumptive eligibility, where you can presume somebody is insured, or that they qualify for Medicaid in a hospital, can also be extended to the street, thinking that if they are experiencing homelessness, we can presume they'd be eligible for Medicaid. And right now, that's still only extended to hospitals, but it should be extended to everybody. And when we've asked what kind of people are you caring for, what are some of their ailments, over 80% has a physical health condition, 60% mental health, and almost 70% with a substance use disorder. So most commonly, the folks had trimorbidities. And so what was street medicine doing to try and alleviate this, knowing that they were caring for people in such extreme conditions with trimorbidities? And so I know this is a little bit busy. Focus on the left three: acute care, preventative medicine and screening, and diagnostic management of chronic conditions. 80 to over 90% of street medicine programs were doing those things. It sounds a lot like full primary care. On the right, you have mental health diagnosis, mental health initiation of treatment, and mental health maintenance of treatment. So not only are they taking care of the physical health, but mental health as well. And I hear folks say, Well, these folks that have a, serious mental illness, severe mental illness, they should have a psychiatrist. And I completely agree with you. But as Coley King says from Venice Family Clinic, I look to my left, I look to my right, there's no psychiatrist. And so we've had to really train ourselves up to practice behavioral health care at the highest level that you can as primary care. We need psychiatrists. We need many more psychiatrists. I saw Iceland on here. And so this is not taking the place of a psychiatrist, but simply doing the best we can in the absence of one. And of course, understanding, as I said, that street medicine is more than just the office visit, even if that office is under the bridge. Over 80% are dispensing medications, almost 50% are drawing labs. This one really shocked me. 60% are doing MAT on the street. I remember when I first heard about this a few years ago, we were at the conference in Geneva, the international conference in Geneva, and I was blown away that they were doing this on the street. And 40% doing point of care ultrasound. Jay Rakeling in Oakland was the first one I ever knew doing this on the street, and now it's becoming commonplace. So the level of care has grown much more than we even anticipated. And street medicine is much more than just the medical services. I think we all understand that folks need more than that. They need that, but they need other things too. And so they're doing things like housing, food, insurance enrollment, clean needle exchange, mail services, clothing services. This was all before CalAIM, which is an initiative in California that pays for some of these things. So there was no reimbursement for street medicine doing these services, but they did it because it was the right thing to do. The other thing we heard, which was a little surprising, but very comforting to me in the interviews, was how much the social teaching of street medicine impacted folks. There's not a p-value for this, but it came up so often, I have to bring it up in this venue. And for those of you who aren't familiar with the social teaching, there are values manifest in action with practical application. It's those values, the philosophy of the work. A lot of people talked about the idea of love and of solidarity with the patients that we're serving. As an antidote to reducing medicine to a science, and also an antidote to allowing our patients to be reduced to a disease, metric, or possession. The idea that if medicine is different from biology or biochemistry, it's because respect for human life or respect for human dignity. And if it's not different, it's simply another science applied to a biped species that we call Homo sapien. I think we all got into this thinking that it was more than that. And this was really played out everywhere that we went, all of our site visits. No matter where I went, there was people in these servants positions really there, not focused solely on the medicine and what the diagnosis was, but providing first the tender love and then the care on the street. And so whether it was in San Diego, in Father Joe's Village, in Oakland, in Reading with Kyle, there was people on their knees trying to get at or below eye level with folks. But that sort of love doesn't always happen on your knees. This is Matt Baer from Clinica Sierra Vista in Bakersfield. And there was a patient we were trying to see on the other side of this river. And Matt was kind of scared to cross the river. And we had Mark Horvath from Invisible People with us. And so I was like, Matt, I was like, the camera's here. You can't not go over the river. Besides, if you fall in, it'll be great. It'll make a great movie. And so he gave into the peer pressure and walked across there. And of course he made it. We saw the patient. And so there's people going out. So what is the typical team makeup in street medicine? The answer is there's lots of different people on the street medicine team, and there needs to be room for everybody who wants to join. The most common team makeups. The most common was APP, so PA or nurse practitioner, a street guide, which fell into many different sort of HR categories: community health worker, peer support, outreach worker, a nurse, and a physician. Those were the top four. The most common was actually the street guide. We found there was only 5 total FTEs for psychiatrists in the entire state, 160,000 people experiencing homelessness. Most of the staff was shared with the clinics, so person sees them on the street and in the clinics, but also meeting their part-time on the street. And most organizations spent less than 20 hours a week on street medicine. So even though there was 26 organizations, most were on the street less than half the time. So these are relatively small street medicine programs. And the stars of it, of course, are the community health workers, the people ideally with lived experience in homelessness, who, like I said, act as our street guides. They put the street in street medicine. And we'll hear from Joseph when we move to the panels to hear his perspective of what this is like. Another thing that came up repeatedly was how we define quality. If street medicine, starting as this, Robin Hood character stealing, borrowing from the hospitals and redistributing to the street, but now we're talking about if street medicine should get reimbursed, we're going to have to answer to the quality. And everybody agreed that quality should be redefined, that different things matter to this population, such as access to bathrooms and shower and clean water, essentially these basic physiologic needs, basic sanitation that was part of healthcare at the turn of the 20th century. And that similar things matter, but to a dissimilar extent, meaning screening for syphilis or hepatitis C, for example, would be a more important quality measure than prostate cancer. I can tell you at USC, our Hep C screenings are about 40%, little less than 40% of everybody we see. So certainly this would be a more important screening than prostate cancer. And so how are we going to define quality? There are no established benchmarks. So one of the things that was talked about a lot was screening for unsheltered homelessness, that we don't know the denominator. We don't know the total number of people that are experiencing this. And therefore, when we think about a quality metric and what the goal metric should be, the right question is not what is the street medicine result compared to the clinic result, but rather for people experiencing unsheltered homelessness, what is a street medicine result compared to a clinic result, or what is that benchmark? And because there hasn't been any reliable screening identifying this population, there are no established benchmarks. And so in the end, we start with the first most important benchmark, which is access, that the best care is the care that the patient can actually get. So if street medicine gets patients healthcare, then that would be more successful than the best care in the whole world in a clinic that's not accessible. We asked about funding for street medicine teams. And there were some very interesting things that came out of it. So some things that I want to draw your attention to is, of course, teams are going to have to pay for clinical personnel, administrative costs. There's going to be a bucket of other costs. But things that street medicine were paying for, that I knew we were paying for, but I wanted to hear what others were doing too, is one, transportation for patients, non-pharmaceutical supplies. So these are like wound care supplies, and pharmaceutical supplies. So these are medications. As you saw before, 90% of the people that we are serving as a state collectively are insured. The vast majority are Medi-Cal. And these are covered Medi-Cal services that are not accessible to people experiencing unsheltered homelessness. So for example, transportation is covered under Medi-Cal, but we need an address in order for them to pick it up. So our patients do not qualify for that. Pharmaceutical supplies, for many reasons, it's much better for the patients and for us to dispense out of our backpacks rather than go through pharmacies to get the medications, which means we have to buy the medications out of our own budgets to have a stock. And so this is the mean spent by street medicine programs, essentially out of their own budget. For us, we do this through fundraising, but these are all things that should be reimbursed by the health plans. And we're trying to figure out how that will look in California right now. When we ask about funding sources, only 24% received any Medi-Cal reimbursement. 5 are FQHCs, so they were billing their PPS rate. And the reimbursed patient visits were between 5% and 85%. So some were billing, but were billing very, very small amounts. 64% reported a patchwork of philanthropy, grants, contracts. This is probably not surprising to many of you. Almost 20% received all their funding, 100% of their funding from a government contract. And so it kind of begs the question, and some of this we've moved farther along in California, is that our local PCP offices, for the most part, our cardiology offices, neurology offices are not trying to look for grants or philanthropy donations to pay for patients' medications or pay for patients' transportation or even for the personnel, not to the extent that street medicine is. And so how do we think about what an equitable payment model might be? And so there are some questions with traditional Medicaid and traditional insurance that surround what an equitable payment model might look like. For example, street medicine, of course, there's really three buckets of what street medicine does, broad buckets. Number one is the stuff we've been talking about, healthcare for individuals, which we can expect in the right model could pay for people who are insured. The next one is this role in public health. This was really highlighted during COVID, but has always been around. I just don't think we really recognized it before COVID, where we're constantly dealing with outbreaks, whether it's lice, scabies, syphilis. In LA, every year there's a typhus outbreak. And we're going to treat, we go to the encampment, everybody who's impacted. You can't just treat the scabies of the people whose insurance you take. You have to treat everybody's scabies. And so how's this going to get funded? There's no pre-screening for insurance. So if you're in a clinic, somebody calls for an appointment and you can say, I'm sorry, we don't take your insurance. You can go to the clinic down the street. But in street medicine, they don't walk around with the assignment on the top of their head. And so you end up treating first. They have an unfavorable relative risk score. So what this means is that this is the shared risk model. So average is 1. If somebody has less risk, it's less than 1. More risk is more than 1. And the idea is that you have so many patients assigned to you, some higher, some lower, that you end up at about 1. Just experiencing homelessness, not even unsheltered homelessness, and no comorbidities, the average risk score is 5.93. And this is for 100% of the patients are at least 5.93. That's the highest risk score. The second and the third highest risk scores are substance use disorder and mental illness. And so you can imagine what a relative risk score is for street medicine patients. So these are very, very complex and complicated patients. Of course, we treat first and ask questions later. We don't worry about what documents they have, when they might get insurance if they're uninsured. We dispense them medications, not necessarily expecting to get reimbursed for it. And then finally, the thing to think about, which is starting to be thought, this gap is closing in California, but is still very much there, is the team makeup and how that impacts billing. So for example, in a clinic, the providers are the ones that bill, and then they have to support the other employees. So you bill for the doctor, and then if a doctor has 2,000 on their panel, there's a percentage of a nurse, percent medical assistant, front office staff, billing staff, et cetera, that is supported. In street medicine, those percentages are much higher for non-billable. You're going to need more community health workers, more social workers. And how can the provider support all of that with a lower volume and the same rates? And then finally, outreach workers as the rate limiting team member. We have outreach workers for many reasons, one of which is safety, go out with our teams all the time. Each team needs one. And so if we're just sending a social worker, not just, but if we're sending a social worker out or our occupational therapist and they need the outreach worker, that adds to the total cost of what that visit is going to be doing. And then also in a clinic situation, this is my last one, sorry. In a clinic, if a patient comes in and they have to see the community health worker and maybe they have a counseling appointment and a care manager appointment and a doctor's visit, and that whole thing takes 2.5 hours, while that patient is being seen by everybody else, the medical provider is seeing other patients. So in 2.5 hours at 15 minutes a pop, they're seeing 10, 11 patients. But in the street, everybody travels like an amoeba. And so the provider is not seeing any more patients when the other folks are doing their thing. And so at the end, we ask people, what are the next steps in the maturation process? What's needed for to continue to progress street medicine for the sake of the people we serve? And so the first one is accurately being able to identify who it is that needs this, such as screening for homelessness. So what's the denominator? The truth is we really don't know. We don't do a great job in our healthcare settings of really screening for homelessness. And therefore, that paired with the fact that there's a lot of under healthcare utilization means that the plans don't know either. And so we don't have much data on this. We need to better define quality because if it's important to know that we're doing a good job. The folks deserve to have the best care possible. And so we need to think about if the standard quality metrics don't match, what are the good quality metrics? Determine equitable street medicine rates. If we want to sustain this work and if the people on the street deserve healthcare, then we have to figure out how to make an equitable rate. Finally, we have to add one of the biggest things, and Jim and I talk about this all the time, is that one of the things we worry about in moving street medicine more into the mainstream is that you lose those values, you lose that philosophy, which is the heart of street medicine and really the reason why it works. And so as this is happening, we have to fight retreat from the street. And so what this looks like is you're doing street medicine, you're seeing, 6, 7 people a day, but you say, if I park at that shower unit, now I can see 10 to 12 people a day. They're still unsheltered. They still need help, right? And so you park at the mobile unit. But when you park at the shower, now you've excluded everybody that can't make it to the shower. And then you say, oh, this is good. We're seeing more people. But if we go to the shelter, now we can see 20 people a day. And so you go to the shelter and now you've excluded everybody experiencing unsheltered homelessness. And then you look around and you say, didn't we used to do street medicine? And then fight regression into the system. If, however this turns out, we are incentivizing the same type of care that we always have, we will get the same results that we always have. If we incentivize volume without the rates to support it, then you will just regress into the system. We talk about street medicine needing direct access to order things for patients like specialty referrals, for example. The patients can't go through their PCP to order these things. And so this is something that is a system-centric barrier that needs to be addressed so the patients can get the care. So we need to fight a regression into the system and just say, well, this is the way it is. Street medicine, you're responsible for fixing that for the patient. And how you fight all these things is you fall in love with the people. And when you fall in love with the people, then you let that guide you and that'll tell you the right decision every time. And finally, I just need to put a plug in for the International Street Medicine Symposium coming in September. It's in London. So hopefully we'll see you there. All right.
Thank you so much, Jim. Before you jump to your panel, and these questions the panel might want to add as well, but there were 2 questions that came up. The first being, did you all win the trust of people experiencing homelessness to have continuity of care with a primary care provider? This question is from Nancy. So if there's any clarification, Nancy, please feel free to unmute and add to that question.
So basically, hi, can you hear me?
Yes. Hi, Nancy.
Okay, thank you. So basically, I know it's kind of hard to bring the homeless off the streets because so many times they have been dehumanized. And I was wondering, going into the streets, have you been able to have a homeless person come off the street and go into the provider's office for continuity of care? I've seen patients in the hospitals, you heal their wounds from, just different wounds that they have over their body. Because they have nowhere to go, they've gone back to the streets. And we see those patients again back into the hospital, trying again to
Oh,
I think you accidentally muted yourself, Nancy.
Oh, I'm sorry. Okay. Have you been able to get the patients to go back into the, to get them off the streets and go into the primary care office for continuity of care?
Great. Maybe I'll start and then we can dovetail into the panel because I know the panel would have, their own answers too. What I would say is I've seen it, of course, but when you're thinking about what is a population level intervention, meaning how do we equip our teams? Looking historically at how the model has evolved over time, and of course, the other panelists know this better than I do. But when we first started, the most common model, which is still out there, is this engage, refer, treat model, where the idea is to engage people on the street, refer them into the clinic, and then begin treatment. And that might work for some, but on a population level, it won't work because it assumes that the only barrier is one of trust. That if you only solve that trust piece, then everything else will flow from that. And we know that that's not true. And then when we started doing street medicine, we really thought of it as transitional primary care, meaning we could provide a certain level of care on the street and with the aspiration of transitioning to a brick and mortar clinic. And my experience has been that as long as they're still unsheltered, that aspiration is too aspirational. We might be able to prop them up with a ton of resources, following team members, bus passes, Ubers, all kinds of stuff for a visit or two, but it's not sustainable. And so once you accept that, then you realize it's your duty to increase the level of care on the street. That if you're gonna just see them on the street, it has to be good care. And so that's what I think we've been trying to do over time. I think that's what you saw in the landscape analysis with the level of care that's being delivered. And maybe we can take this time to introduce, if the rest of the panel can introduce themselves, and then you can answer the question. Maybe Jim O'Connell, you're first on my screen.
Sure, thanks, Brett. And actually, thanks for that great presentation. I was sitting here enjoying it immensely. I think your question about trust, of course, is huge. And it brings up just what Brett was saying. You can go out and spend a lot of time earning trust, which is, I think, one of the things we all invest our time in. And it takes time. It's something you can't do in the traditional clinics, just don't have the time. But then the issue you bring up is, what about continuity of care? And I think that's something I talk to Brett and Jim Withers and others about this all the time, is I think there's one principle that says we want to make sure we're bringing, we think the people living on the street are worthy of the best possible care. And why is our system not doing that? So I think there is a role for street medicine, for learning what to do out there, but then also being a catalyst within the mainstream to make sure these people are taken care of well. And the example I'll give you, Nancy, is that, on our program, we get started with a mandate to have a board of homeless people telling us basically what to do. And their biggest concern, interesting, this is back in 1985, and this is a combo of people living in shelters and on the streets with the time of getting no care, was they felt when they went into the hospitals with the sicknesses that so many of them had, that's when major things were going on. They felt most frightened. And what they wanted is a doctor and a nurse and a social worker or a team that they could trust, even when they're in the hospital, as well as when they're outside. So we got caught in a little thing of trying to understand what continuity of care and the delivery of good quality care. Now, mind you, this was also we were forged in the crucible of AIDS, and AIDS was very difficult to treat only on the streets because there were so many opportunistic infections that you really required the specialty clinic. So I think a challenge for us, which Brett has articulated a lot, is we've got to get out there and do exactly what we need to do on the street. But I think we also have an obligation to make sure we work hard to change the mainstream so that they don't stigmatize the people we have.
Thank you both, and I agree with that. But I think one of the challenges that I also, if you don't mind me saying, is that when you have them on the streets, they move from place to place to place. So it's kind of hard to keep up with them on the streets. I worked for an FQHC, and I'm beginning to hear the same problems with those providers. They do not have enough time to see the patients. Because we all know that patients, homeless patients, are considered as what they would call train wrecks. So I guess my concern is even going on the streets to provide the medicine for them on the streets, they move from place to place. I've seen that happen in the community where I live. I've been communicating with this man, homeless man, and I asked him if he had a provider who can see him from time to time. He felt going to the emergency room was best for him because it's free. They have to see him. But I'm still looking at, I'm looking at his eyes. I can see, his liver is, he's an alcoholic. He's deteriorating. And this is one of the reasons I decided with my business to go into the homeless shelters. Connecting the patients with their primary care provider is a little easier to manage once we get them stabilized in housing. We provide the transportation for them to go to the provider's office. But I really, I'm enjoying this, knowing that we do have the homeless patients on the streets being taken care of. I think you all are doing a great job.
Thank you, Nancy. I think I'll direct the question of continuity, how we follow patients, how we don't lose people, because there are people that we've taken care of for many, many years on the street. Maybe Joseph, that's one of Joseph's main roles for us, is make sure we don't lose people. Joseph, can you introduce yourself and maybe anything you have to offer to the question?
First of all, I don't know how I ended up on this panel of street medicine superheroes with the providers, but hey, thank you. My name is Joseph Becerra. I'm a community health worker here at Keck School of Medicine in LA. I don't quite understand. What was the question you asked about?
She was asking about that it seems very hard for her to find people on the street. How do we find people so that there's
continuity? So a lot of times that is a major factor, right? Is because when they're on the streets, a lot of them get pushed away, they get ran away, or else they move a lot to either for resources, food, safer environments, or just being around people they can trust. So a lot of times what we do when we connect with the patients themselves, we kind of take an inventory on the places they go and the people that they see on a daily basis. So we try to make sure we know like who their friends are, who their family is, and where they go for food or where they go for maybe to charge their phones, those that have phones, or maybe just to panhandle. We ask about recycling, like where do they go for recycling? So we just try to always keep an inventory on the places that they go and the people that they see. That seems to be the best way and then are we successful? No, we're in Los Angeles. There's a whole lot of people and a whole lot of places to go here. But a lot of times we are, because we make sure we understand the person themselves and where they go and who they hang out with. So we try. I mean, we don't see them every week, but we see them, they'll reappear after, we can't find them for a while. So that is a challenge, I think, in this street medicine, and it always will be. It's just too hard to always find them.
Just to brag about Joseph a little bit and the way that that the CHW's work is we have a consult service at the county hospital where we see people in the hospital and follow them on the street. It's hard to find people because they're somewhere in the streets of LA. We haven't met them on the street, met them in the hospital. And over 70% of the time we can find them and give them at least 3 visits for continuity.
Thank you all.
Jim Withers, you want to introduce yourself? And anything you want to add to those questions?
Hi, honored to be on this panel as well. So I'm Jim Withers. I do street medicine in Pittsburgh, and am associated with the Street Medicine Institute. I thought your presentation was incredible. You just keep getting better and better. Yeah, for me, I think there are a lot of ways to look at street medicine, which you and Jim and Joseph have alluded to. But one of the ways, besides, how do you get the best care to people in those arenas in which they are living, where access is poor? I mean, that's critical. We know from Jim's studies that the mortality rate is 10 times that of the population, higher than the so-called general homeless population as well. But I'm kind of obsessed as a practitioner, as a teacher, on exclusion and inclusion of how do we adapt our love, ultimately, our commitment to the reality of people who don't fit into the system. And so you can say there's maybe more people here or wherever, but I always find the folks that are most disillusioned and most traumatized and most excluded are almost a litmus test for our humanity and our commitment to each other. And so I do eternally focus on the people that are least connected. And so for me, that's a marker of my personal and professional significance, is if I can find a way to be present in those realities. And I've chosen the streets as the arena for that. So yeah, there are other ways to look at it in terms of cost and efficiencies and changing the system. I agree with Jim on that. I think the radical commitment we make to the people that everyone else sort of looks at as uncooperative or unwilling or unworthy, I think is a challenge, intentional challenge, to a larger system, which can't be all things for all people, but has to be reminded that the system isn't the center of the universe for lots and lots of people. And so that's kind of where I'm at. I have nothing to add in terms of all the amazing insights that you. It's actually breathtaking to hear how fast things have grown, especially in California. And I know Jim O'Connell's been at this longer than me, one of the few people, but I think we do see an acceleration towards a consciousness change that says, gosh, we got to get out of our own, buckets and start looking not just at the people in the waiting room, but the people who aren't in the waiting room, as not just an act of social justice, but as also as one of a transformation of ourselves, and a reclaiming actually of the dignity and sanctity of healing professions, because that's being stripped away from us as well. So I do think that we are a challenge to the system morally and in many other ways. It's a great honor. I would always say that being with people on the street has been a great privilege, that they're willing to accept us into their lives with trust, and that those relationships, I think, are probably the most important thing.
Wonderful. Thanks, Jim. Corrine, you want to introduce yourself and anything you want to add?
Wait, some like tough acts to follow.
All right.
I'm Corrine Feldman, and I'm at USC Street Medicine. I'm a physician assistant and also the director of workforce development and education for USC Street Medicine. I think two things come to mind. One is that, and I kind of put it in the chat, but I think this idea of continuity of care has a lot to do with us, and maybe less to do with the patients in terms of being able to find folks. And I think we have to be really honest about what is our what is the street presence, right, in a particular community, and how frequently are you there, and how can you sort of become embedded within a community, so when people are moved, there are other community members that, you know, help. We find this all the time where we can't find someone, but we've been coming to the same area for, you know, 3 years every Tuesday morning, roughly around 10 o'clock. And so the community kind of helps us find folks that might have been moved. And so I think sometimes if we find that folks get lost if we haven't shown up, right? If sometimes it's like there's a holiday on a Monday, and we really have to prepare our clients and our patients and let them know, you know, if we're not going to be there, and where might you go, kind of to Joseph's point. So I think some of it is kind of looking at our own street strategies to really ask ourselves, like, how are we being present consistently in a particular community? And then the other piece, though, is this really important piece of continuity of care and bridging people into, you know, either clinic-based primary care or specialty care. And I think that has maybe the most successful recipe so far, I think, that I can think of, is the humility of the street medicine team to say, you know, we really care about you, and we really can't provide for you what you need in this setting. And that accepting like clinic-based care doesn't necessarily mean a severed relationship with the street medicine team. And we've had that, you know, recently, many times actually in the last couple of months, just having that honest conversation, but also not making it feel like the sort of ultimatum of like, choose the clinic or choose this, in some ways, like very supportive relationship that you have with this team that comes and sees you and knows you really well. And so kind of sticking with people during that transition and after. I mean, we've had patients that had terminal cancer. I was no longer doing their primary care. I was no longer, you know, really doing any of that other than kind of acting as a medical interpreter for them and their family as they navigated the system. But we continued to see them and be engaged with them because we didn't want them to feel abandoned because they had gotten much sicker. So those are just kind of my two comments.
Great, thank you. I actually like this better than some of the questions that we had prepared. Maybe we'll just open to the audience. Katie, I've lost track. I see there was like maybe almost 60 comments or questions. Do you have any of those?
Yes, there are
Okay.
some great ones. You're absolutely right. So let's see. The first one, it's a few directions to go here. Do we want to go nutrition, reimbursement, or let's start with this one, because regarding dispensing meds from backpacks, how do you handle different types of substances? Can you talk a little bit about the safety, and particularly they mentioned controlled medications, but in general, safety concerns, how they've arisen, how your team addresses them?
Who's going to go on that one?
I can go first if it's just about dispensing medications, and then is it safety concern about medications or in general?
It was mentioned as a layer to the medications, but I think it was a safety in general, although specifically recognizing that having controlled substances may or may not, and maybe you could speak to that. Does it actually increase? I think there's a perception that it does.
Yeah, well, for us, and Corinne and Joseph and I are all on the same team. The gyms might have a different answer or better answer. For us, we don't carry controlled substances. I think we carry about maybe 40 or so medications, but it's nothing people are interested in. Antibiotics, hypertension meds, asthma meds. And the important thing when you're dispensing is to know your state's physician dispense laws. Every state is slightly different. California is one of the more strict ones in terms of even down to the font size that has to be on the bottle. You definitely are going to have to track lot number, expiration date. There are a few services that you can get online that are essentially pharmacies that will ship medications pre-packaged and pre-labeled to you. When you dispense, you just log the inventory in their system and they'll alert you if there's a recall. And it's very reasonably priced. So that's what we use. It just, that way we know we're in compliance. We haven't come across any safety issues with the meds.
Can I kind of add? A lot of times we don't have controlled substances. We just have a bunch of medication in a backpack. So sometimes if you're on the street and, people are walking by, whether it be homeless, whether it be just whoever, they see a bunch of medication in the bag, and sometimes they can assume, hey, that's meds, right? They thinking Oxycontin or thinking Vicodin or thinking a bunch of different stuff. So it matters where you're at. So we have different teams in different locations, and who the provider is at the time also. We tend to leave the bags in the vehicles, the medication bags, and the provider can just go to the vehicle, pick what they got to take out, while the community health worker, or whoever it may be, us, community health worker, stands, by looking out, making sure nothing fishy is going on, grab the med, do what they have to do, and just come back and give it to the patient. But a lot of times, they don't know what's in those bags. They just see medicine. So I would always say just be precautious no matter where you're at, especially on the streets all the time.
You can go to the next one. Oh, go. Yeah, go ahead, Irene.
Hi, everybody. My name is Irene. I'm a PhD student in sociology at UCLA, and I'm studying the implementation of street medicine in California. And I have a question for the panel. Why do you think street medicine is developing so fast, specifically in California? Like, what is it about California? Other than having such high numbers, of course, of homeless people, but New York City, very similar to LA, right? But I don't know if we are seeing such development in other parts of the country. And I wonder why you think that's happening and why now? Like, we know, I've read Jim O'Connell's book, like they've been doing this for so long, right? Like, why now? What is it about this time in the country or whatever that is behind this exponential growth? Thank you.
I've been making trips to California to facilitate street medicine programs for a couple decades. We had our second international symposium in 2006 in order to kickstart the program in Santa Barbara. But I think it's only recently, and I'm going to give Brett and Corinne a lot of credit for galvanizing the vision around it. It may or may not be a coincidence they came from outside of California. A lot of times, I think the introduction of a new level of clarity from outside does help precipitate things in terms of developments. But, Brett and Corinne have a really, really clear notion of the specific value of working on the street. I think California has always been innovative, and in San Francisco and in other areas, Los Angeles, they've dealt with the issues of homelessness for quite a long time in a larger context. And I think that sometimes the signal to noise ratio gets lost in some place like Skid Row or, in San Francisco, where so much has been done, but you don't even know where to start sometimes. And so I do think that they brought a certain clarity. I think the economic and social factors that are causing rough sleeping explosion is universal, but definitely nowhere is it as extreme as in California, a lot of which is due to housing prices. But I think I always found, this is just my pet feeling about California, is you guys are cursed by your own humanity, your kindness. And I've seen that in other places like Boston and in Seattle and Portland, because a lot of part of the country, we can just keep judging people and shaming them and pretending like it's their fault. But there's a certain consciousness and movement towards social consciousness in some of these centers that force you guys to have to come up with some kind of an answer to something that you're seeing. So I do think that that's another reason California is innovative. But I just think it's a time in history, and this is true globally because I do a lot of traveling around the world. I think we're reaching a tipping point of having to, at least in some portion, deal with the us and them mentality that's out there. I don't think we're going to cross a threshold and suddenly all be sisters and brothers, but I do think that we kind of go through cycles of having to pay the piper for lack of attention to these deeper social issues. So I'm rambling a bit. I'm so thrilled that you're working on understanding this. I would love to hear, your conclusions and thoughts. I think we need partners that kind of look at what we're doing more objectively and tell us what they feel about it in terms of social significance.
Thank you.
Brett, let me second everything Jim is saying. The first thing I would second is that I think, in answer to your question, Irene, a lot of what's going on now, I personally attribute to not only Jim Withers going around the world and catalyzing people, but particularly Brett and Corrine and what they've been doing, systematically looking at it rather than looking at it as a gamish. But one thing to keep in mind, at least when I look at it from the East Coast, is in a place like, and one thing we have to always cope with is street medicine is going to look vastly different depending on where you're doing it. So coming up with principles that apply to everybody is really tough because we all live in such different, it's like all politics is local. I think all street medicine is in some way got to be local. But for example, in Boston, 95% of everyone who's homeless in Boston is in a shelter. And only about 5%, only several hundreds of people are on the streets. So in Boston, we can actually name everybody who's homeless on the streets. And we're a small geographic area, so we can go find them. You can't do that when there's 60,000 people in your county on the streets, in San Francisco, when there's so many people spread out, Seattle. So when you think of, I always think of it sort of west of the Mississippi, you tend to have, fewer shelters and more people in the unsheltered world. And I think another question might be another thing to look at, Irene, in your study is that I think about 2 or 3 years ago, for the first time, HUD's counts, the point in time counts, which are deeply flawed, don't get me wrong, but for the first time, there are now more unsheltered people in the country than sheltered adults. So I think that's just, it's calling out that this is, as Brett and Corrine said, this is the time. And I think it's, this is perfect. We need to be looking at this. And it is, you guys are out there doing work that's showing all of us in the healthcare system the real weaknesses in how we exclude people from the best of care.
Good, Corrine.
Yeah, I just want to add really quickly, because I think every movement has various tipping points within it. And I think if we look at kind of the movement of movements in the last couple of years, there's really been incredible progress in a lot of different movements that are really kind of built off the backs of different, community organizing groups and various kind of stepping stones that have been laid. And sometimes you get to be alive during a time when there is a significant tipping point. I think we saw that, a lot in the last couple of years and during COVID and George Floyd and things like that. And so I think that there is a level of consciousness about action, the difference between admiring a problem and being an active part of a solution. And so, from an educator's perspective as well, when I see things like resident congresses for family medicine saying their number one initiative this year was they wanted training on street medicine, and they kind of almost demanded to the AAFP that this is what we want as our sponsoring and kind of supporting organization, is we want education on street medicine. And so to me, like, that is really indicative of our kind of future workforce of family medicine physicians and, PA students and nursing and stuff, saying, we want this as part of our curriculum because this has to be how we take care of our communities. The folks in residencies and that are current students, they are, they have been observers of kind of all of the things that have been happening around them. And now is their opportunity to be part of a solution. So I think, education is a great force of nature, and I just see a lot of that kind of demand, and then the system responding by saying, okay, well, we got to figure out this thing, that people are asking for in their undergrad classes and in their graduate school, in their public health degrees. Our engineering school reached out, was like, what can we have our engineering students make that would help, like, with folks, experiencing homelessness in LA until housing can be built, recognizing that there's a future, but there's also the right now that you must respond to. So I think that, that's an empowering strategy to put it in that perspective.
Just want to add one more thing, because I think that the tipping point, I think maybe a few people said that, is that we've been watching the gyms kind of build this for a few decades, up. And when we did the landscape analysis, remember there was 25 programs. This was before really street medicine was reimbursable. Street medicine becomes reimbursable. Caling comes out, you can get paid for care management, and it doubles in 1 year. And it takes about a year to start a program. And there's, another 20 plus in development. And so all these other programs throughout the history have really had to fight to exist and fight to survive. And what if care was equitable and we just, were able to take care of the people the way that they deserve to and sustain a program? I mean, the one of the beauties about some of the financial numbers and information of the landscape analysis is this is all unfunded work. So it's not bloated. This is what lean looks like. And now that the place of service code has come out and there's an opportunity for this to spread across the country, we still have to figure out rates. But as it's spreading across the country, I'm hoping the rest of the country sees a growth like California has in the past year.
One of the things that you've mentioned, and I think we keep having to recycle, is thinking about as we grow and evolve in these more liminal, edgy delivery models, is avoiding that retreat from the street, and the commitment, the radical commitment to the reality of excluded people. I think we have to keep reminding, because we forget, we have short-term memory loss, and suddenly we're system-centered and we're thinking about, how's this going to serve the system? How's this going to serve me? And I think it's a bit unnatural to really keep reminding yourself of how it looks outside of the convenience zone. And so I think one of the blessings of the street medicine movement, and again, it's not the only arena in which we're trying to reach out to excluded populations, but is to keep challenging ourselves as the steward of that principle as much as, you know, the models and the techniques, et cetera. Because we tend to, it ends up becoming about us really way quicker than you realize. So I would just say I love all you people that are part of this webinar and who are doing this kind of work. But I do think that we have to hold ourselves accountable to that as well, because you can lose it like that, and then it's not about them, it's about us.
There was a question that I'd like to start by asking Joseph, and of course would love everybody's thoughts on this. And it was kind of a general topic, but specifically saying, how are teams addressing substance use in terms of engagement, and the way it impacts how you approach somebody, what types of services you tend to see somebody interested in engaging in when substance use is kind of part of their reality at the time of engagement?
Nice question. So basically, street medicine is about meet the people where they're at, right? So our thing is we're going to help everybody we can help, everybody who wants the help, everybody who needs the help. Substances are just so many just tricky things on the street. And, you know, a lot of people know, and a lot we went through this, substances now seem to be used more for survival than just basically getting high. So, I mean, we do a lot of harm reduction. We believe in harm reduction. So first thing is to, you know, let's, you know, meet them where they're at. Let's help them maybe lower the use. And, you know, when they're ready, if they're ready and when they're ready, help them get to the next level of maybe some type of treatment or some type of more help that they need that we're not able to provide once a week or, you know, as often as we see them. And I mean, you know, with substances, it's all about you wanting the help too. So it's such a tricky thing because, like I said, a lot of survival comes with it, and you can't blame some of them for using the drugs when they're on there. If I was homeless, I'd be using drugs. I mean, this really, you know, I want to numb the pain of being out there. I don't want to have to really think about me in the big picture, right? I mean, me in the big picture, being homeless, not having, or just whatever it may be going on, sick, you know, so many different, family not there. I mean, you know, so I don't know. I think it's just so broad with the substances, but we try to help them as much as they want the help. And yeah, of course, we're gonna try a little bit harder than them sometimes. But I mean, you know, since it's so patient centered, we're gonna be there for whatever they need. I don't know if that's any answer, but
I think that's
Oh, sorry. I just wanted to jump in because I think, you know, working with our CHWs and at least our philosophy on our team is that, you know, harm reduction should be part of healthcare, that it isn't kind of relegated as a task to like one team member or another. But I definitely think that sometimes I rely on Joseph or Gabriel or the CHW to kind of vouch for me to the patient that I'm okay with them telling me the truth about kind of what they're up to and what their habits are, because I think the stigmatization of substance use from the healthcare system, and I'm sort of a walking representative of that until the patient gets to know me. And so Joseph will often have sort of this like side conversation or like standing behind me being like, she's all right, you know, to let me know or let them know that we can talk about these things and that, you know, it'll be in a non-judgmental way. So I think it really speaks to that teamwork and that collaboration because it helps everybody. If I know kind of exactly what's going on, you know, I make hopefully better decisions with the patient on what the next steps are for their health. So I think just once again, we're big fans of CHWs and peer supports for so many reasons, and that's one of them. Sometimes the conversation our CHW has, you know, I get in the car and I say, Joseph, what'd you guys just say? Yeah, I don't understand it at all. And then he like gives me the 411 on what exactly just went down. That's fine. Like, I don't need to understand it in the moment. But somebody needs to be able to have conversations that I just don't have the skills to have. So
I'd like to, sorry to put you on the spot, Jimmo. I'm wondering if you could answer this too. I mean, over the years, I've just seen you guys do so many innovative things with substance use. I mean, you were doing Suboxone, you know, very early adopter of that, the spot, of course, many other things I'm sure I don't know about, but all that has a philosophy behind it, I'm sure.
Yeah, thanks, Britt. And I would, I just, confirm what you just said, Corrine, and Joseph, you said it perfectly. I think we've learned that the problems associated with substance abuse have flexed over the years. And initially was if you use a needle, you might get AIDS, and AIDS would kill you 2 years later. Then fentanyl comes along, and you can die with the first shot. So we've had to learn how to roll with that. And our board members, and Joseph, I'd be interested in your thought on this. We found that there's not like among the homeless people we serve, there's not a universal feeling about how we should do it. Some believe in harm reduction. Some say I would never have gotten sober unless you pushed me into a program. So they're all over the place. So we've had to learn how to be really flexible, but we do abide by harm reduction, and that we try to give everybody, just like you said, Suboxone. We've got tons of people on methadone clinic. And then we have to, what that requires is a lot of visits, a lot of seeing people, because you've got to see them frequently. And then we're trying to balance that between the visits for diabetes and other stuff, So I think we all face a huge challenge of how to integrate good care of substance use disorders into the mental health and physical health that we're also doing. And I think that's a topic I would urge, Brett and Corrine, you've probably already done that many times, but I think we all ought to talk about that sometime. It's a real challenge to our staff and all of us.
I think a big part of that, Jim, also is what you're saying. I mean, it's relationship, right? It's trust, it's consistency. The more they see us, the more they talk to us, the more they know we're going to be there and not just walk away, the more they trust us enough to say, hey, maybe, whatever it may be, maybe it is time for me to stop. Maybe it is time for me to slow down. Maybe it is. We met this gentleman the other day that we had placed in a hotel. And when me and one of the providers went to go see him, he started crying and saying, I'm embarrassed. I'm ashamed because I'm using drugs still. And first thing we said was, hold on, it's okay. Don't be embarrassed and ashamed, because the more embarrassed and ashamed you are, you're not going to want to see us. You're going to withdraw from us. And that's the last thing we want. We don't care. We care what you're using. We care what's happening. But what you do is what you do. And we're still going to see you regardless of what you do. But the good thing about it is you have a conscience about it. So that's saying, hey, maybe you're kind of ready to slow down. And if you are, we're here. So, I mean, it's just the trust in the relationship, I think, that is just big.
Our time here is rapidly winding to an end. So I want to give each of the panelists a chance for a last minute thought. I'm going to pose a question that you can either dodge or choose to incorporate in your final thoughts. And it's really talking just kind of about the demonstration of the value of this work, both in metrics, in research, program evaluation. Are there things that you all, as the founders and the early pioneers in this work that are leading us all forward, have found have particularly spoken to your communities that create buy-in, certainly financially, but even just conceptually? So you can choose to address or completely bypass and end with your thoughts for today.
Why don't you guys go in reverse order of how you introduced yourself?
Oh man, that was an hour ago. I think I went last, so I'll I think in terms of metrics and all of those kinds of things, I think they are both equally important and also frame a larger question, which is how are we defining success and what makes sense in terms of defining that success for an individual, for a team, for a population. And so and it actually kind of speaks a little bit to the question that is going back and forth with Matt Hing, which is such an amazing and well thought out question that it actually keeps us awake at night, right? How do we join the mainstream metrics and accountability and things and billing while maintaining kind of this viewpoint? So I think my 10-second answer is the way we do what we do is really, really important. And I hold out a lot of hope when we look to people from, say, the palliative care sector, who really built a sector of medicine that was based on love and based on inclusivity. And I haven't met a palliative care doctor who kind of falls out of that, and so they've been able to maintain and have metrics and things that make sense for the population that they're serving while maintaining the heart of the medicine.
I think it's multifaceted, and you do take advantage of what you can. I remember in '92, I wrote an article with 75 references and submitted it to JAMA about I didn't have a name for it yet, but this thing that I was doing and how it was so intersectional with medical education and social justice and healthcare delivery. And I got rejected. And so you kind of regroup and learn more, get deeper wisdom. I think all of us have done our local and continue to do our local advocacy, learning. It's like your local city is your testing ground for understanding the community of stakeholders and how there's all kinds of characters out there. Some people are great allies. Some people have other characteristics. And to sort of market what you're doing as valuable can take different pathways at different times. I think you just have to be really careful that that your focus is on not your own background music and your own maybe agendas, but is it really serving the people on the street? But I do think that if you can pick off like Jim, and I know that in California there's been a number of centers where they actually have the capacity to get data. That's great. P-values are great, and that really speaks to a certain dynamic. We've had a lot of discussions about speaking the language of cost effectiveness. And you can make some arguments there, but again, as Jim O'Connell says, it may just turn out it's more expensive to treat people who are really struggling and who are on the margins of society. And so the question is, are they worth that effort? Is the ICU worth even visiting, where people are dying and struggling? And that's a Paul Farmer question there. I mean, that's a real human value question. You could speak to the moral issues and some people will respond, but that can get very mixed with politics and such. Another way to influence your community is to encourage the learners, because they tend to become an amazing development of a new vision for the future and a workforce that teaches us old timers things, and then takes on and is validated about their vision for themselves and for society. So that's like our sleeper cells is all of our students that go out there and change the world. I think what we need to do is begin forcing ourselves and others to think about the fabric of community itself, and if there's a voice for people on the street, and can we create an actual real forum in which people can, in a Freirean sense, take their power back. and be members. I love how Jim McConnell always references that start point with listening to the people. But I think that's something that we have to actively try to struggle to do to create a new fabric of society in which we're responding to those voices and making that normal for the rest of society. So I think people want to not be assholes, but they need a lot of help creating a framework for that.
Beautifully said as always, Jim, and I have little to add to that. I realize that time is over, so I survived by letting the time get past. But the only thing I would share with everybody is just remember, one is I'm so honored and thrilled that this is all happening. It feels like the blossoming of a seed that's been working for a very long time. But I would say, remember, this is a journey, and we have to stay humble. We have to keep, pushing ourselves to see what is good care on the street versus not. So keep that going. I think that's what will keep us all together and sharing with one another. So I just leave you with that. I am so honored to be part of all this, and to Brett and Corrine and Katie League for organizing this. Thank you so much.
Thank you, guys.
To be among you all is such an honor. Thank you for this time. No surprise, 90 minutes was not enough. And to all of you who joined and stayed, and the gifts that you were given from this community, I hope it inspires and lifts up your work, because this is where we have to return to remember how meaningful it all is. Thank you all for being here. We will send out the recording and look forward to holding future conversations with these brilliant, brilliant people. Be well, everyone.
Bye, everybody. Thank you.